Assalamu alaikum. Good afternoon, good morning, good evening, wherever you are joining us from different parts of the world. I'm Dr. Sohela Chima. I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine, and also an Associate Professor of Clinical Population Health Sciences. So a very, very warm welcome to all of you. And for those of you who are observing, fasting, Ramadan Kareem to everybody. So warm welcome again to the Population Health and Wellbeing series. As many of you may know, the objectives are to discuss contemporary critical topics that are relevant to healthcare, medicine, and population health. We also examine evidence-based practices germane to public health and patient care. And we also describe opportunities and challenges in the evolving face of healthcare and population health. Some housekeeping, your cameras and microphones have been turned off. You can post your questions or comments either in the Q&A feature, the tab that we have, or you can also just post them in the chat. So don't worry, we are able to see the chat and we'll be able to take your questions or comments from the chat also. The questions will be addressed at the end of the session, and I will moderate the Q&A session for Dr. Hallal. So this is an accredited activity, and it is accredited both by ACCME and also by DHP here from the Ministry of Public Health in Qatar. So this is important for all of those, who are licensed in Qatar and would like to use credits, for relicensure. As you all know, basically there was a circular which came out December the 19th from the accreditation section, Department of Healthcare Professions, Ministry of Public Health, that basically said that they need your Qatar ID number and MOPH license number. It has to be provided to the provider. So in this case, we are the provider of the accredited activity. So please update your profile on Cloud CME, which is the WCMQ registration portal. Once you sign in, click the yellow My CE button to the right, select profile, and review and update the fields as required. Please note the deadline to update the profile is today, which is March the 19th, okay? So this is very important for all of those who are licensed in Qatar and are going to need credits from this session. So the post-activity evaluation will become available in the Cloud CME account by March the 25th. And healthcare practitioners who are licensed in Qatar, they will only receive their credits once the QID, the MOPH license number has been provided. And this needs to be updated in the profile. We are not going to be emailing y'all anymore to get this information. We've been reaching out to people. The notification has been clear from the government. This is something that you need to provide to the providers. In this case, it is us, WCMQ. So you will receive an email notification once the evaluation is available. And then once you complete that evaluation, your certificates will be available for download automatically. So we have a very interesting topic today, who our expert speaker is going to be talking about. So it gives me great honor and privilege to introduce our expert speaker for today. His name is Dr. Ali Hallal. Dr. Ali Hallal is an associate professor of clinical surgery, and he is currently the director of the surgery clerkship at Weill Cornell Medicine in Qatar. Dr. Hallal's clinical expertise is in trauma surgery, surgical intensive care, and upper gastrointestinal oncology surgery. He has an extensive track record in surgical education and acted as the program director of the surgery residency and the trauma and intensive care fellowship at the American University of Beirut Medical Center. Dr. Hallal's recent interest is conflict medicine and global surgery and its integration into medical education. He was involved at the national and regional level in the establishment of trauma and critical services, the development of the ECMO program, directing advanced trauma life support courses, teaching general surgery and acute care review courses in the MENA region and Europe, and the organization of several congresses and webinars related to conflict medicine. So Dr. Halal's going to talk to us about global surgery, surgery inequity in low and middle income countries of the Middle East. Dr. Hallal, a very, very warm welcome to you, and over to you.
Well, thank you, Dr. Suhaila, for the kind introduction. Good afternoon, everyone, and Ramadan Kareem to all. I want to thank Professor Mamtani and the Institute of Population Health for giving me the opportunity to speak today. I just want to mention that and want to clarify that by all means, I don't consider myself expert on the subject, rather a surgeon who has an interest in learning more about global surgery. And I'm looking forward to share with you what I have learned in terms of information. So let me start by sharing my screen. Okay. So the title of my presentation today is Global Surgery, Surgery Inequity in Low and Middle Income Countries of the Middle East. I have no disclosure, no financial disclosure. The only thing I want to disclose is that I have incorporated some of the slides that belong to Professor Mira. Professor Mira is the lead author on the Lancet Commission, and his slides do not have any proprietary conditions, and he has given permission to use for education purposes. So the learning objective. I will try to define global surgery, try to discuss the burden of surgical condition in low and middle income countries in the Middle East, summarize direction to meet the surgical need of the population involved, and outline action to reorganize medical education in a region ridden by endemic conflicts. So global surgery, how did it start? So before defining global surgery, most of the attention and funding in global health has been dedicated to addressing deadly communicable diseases such as malaria, tuberculosis, HIV/AIDS, as well as some non-communicable diseases. Up till the beginning of this century, surgery has not been a topic of public health discourse. And this is because the public global health paradigm has been of a disease-based care. Surgery is a treatment modality and is needed across the entire range of human diseases and is not a distinct entity such as HIV, nor does it target only a specific demographic group like pregnant or pediatric patient for its data to be easily captured within the epidemiological framework. In 2003, the Lancet published this paper comparing the global and the regional mortality from 235 causes of deaths for age 20 and above. And then they compare it, they had two groups, one in 1990 and the second group in 2010. And basically, the data was extracted from the Global Burden of Disease study. And then if you look closely at the reported data in these two pie charts, you do not actually see any surgical condition, but rather just disease entities. Without a deeper analysis of the raw data, it is difficult to figure out what is the mortality from perforated appendicitis, as an example, from this data set. So some fact, I'll come to that. More than 500,000 women die each year in childbirth. These deaths are largely attributable to an absence of surgical service to cause postpartum hemorrhage. In some settings, survey revealed that surgical disease is among the top 15 causes of disability. In the early 2000, so this is how it started. In the early 2000, Paul Farmer is an infectious disease physician, a medical anthropologist, and a professor at Harvard. He experienced the death of some of his patients he was trying to treat for AIDS in Africa. And what is interesting is that his patient died from surgical conditions, not from AIDS, from surgical condition, sometimes as simple as appendicitis, which were left untreated because there were no surgeon or fewer surgeons per population. His interest on this issue grew deeper when he realized that the literature, I'm talking about the literature at that moment, which is like in the early 2000s, contained some data, mostly in form of survey. So these were purely survey, stating that surgical diseases is among the top 15 causes of disability, and that surgical condition account for 15% of total disability adjusted life years, daily lost worldwide. And then, so basically, he therefore published his paper. This is a very important paper, which the title, Surgery and Global Health, A View from Beyond the OR. And within this paper, he quoted, basically, he called surgery the neglected stepchild of global health. So what is the exact definition? So shortly after, global surgery was coined in the medical literature to describe the practice of surgery in areas of inequity. And then the exact definition is the following. Global surgery is an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who require surgical care, with a special emphasis on underserved population and populations in crisis. It uses collaborative, cross-sectoral, and transnational approaches and is a synthesis of population-based strategy with individual surgical care. And you could see here that I underscored special emphasis. And I did that because global surgical inequity is not only present. It is very important to appreciate this concept. It is not only present in low-income and middle-income countries. In many countries with advanced economies, individuals who are indigenous, who are poor, who are uninsured, or from an ethnic minority, or live in a remote area, are also substantially less likely to receive adequate, timely surgical care. The other issue is that conflict and conflict displacement and natural disaster can also result in the sudden absence of surgical care, irrespective of a country's development status. So, inequity, it is important to understand from the slide that there is inequity in terms of surgical care. It affects mainly low income to middle income countries globally, but it can also happen for a small proportion of the population within a country who has an advanced economy. So global surgery underpin the emergence of the term global surgery. So basically, it is the term global surgery is a desire to link surgical need with the overall agenda. This is the main aim of global surgery. And then for global surgery to be understood, it is important to review this very important document, which is the Lancet Commission, which was published in 2015. I will basically discuss this document a bit in detail because this is the only way I can clarify global surgery. The Commission was led by 3 investigators. One from Harvard, Professor John Mira, one from King's College in London, Professor Antti Leder, and then another professor from Lund University in Sweden. And the main goal of the commission was to define first the status quo. What is the current global burden of surgical condition? The second goal was to come up with key messages, then few recommendations, but most importantly, to come up with indicators and metrics that can easily be measured with the aim to inform and drive policy change, and ultimately to address the gross inequities and improve global health. So the investigator restricted the design of the global surgery definition, restricted the design of their investigation to global surgery definition. So basically, it is important for them to study it from a perspective that it will improve health and health equity for all. But the scope of their study did not include all the population, which is underserved population and population in crisis, but rather only the underserved population in low to medium income country and high income country. So the paper that came out from the commission did not look at population in crisis, and I will not discuss that in the first part of my presentation. So the first challenge was to estimate what was the global burden of surgical conditions, because there was no information about that. And then so basically the first estimate was derived from the 2002 World Health Report burden of disease. And so what they did is that they asked 18 surgeons from around the world with a lot of experience to look at this estimate and to figure out what is the proportion of the reported diseases that might need surgery, in their opinion. So it was an expert opinion. And they concluded that from all the reported diseases globally, 11% of the reported disease will need to have surgery. And then if they do not have adequate care, then that will constitute around 11% of global DALI. The second estimate was derived by looking at the actual mortality and morbidity of the health system and scaling up the surgical package to a package comparable to first level hospital. So there was an estimation. They analyzed 4 digestive disorder, 4 maternal and neonatal disorder, and simple injury. And then, so basically what they did, they calculated the avertible and non-avertible mortality and morbidity from this small number of surgical conditions within the 3 defined category of digestive disease, maternal, and injury. And then what they found is that when you scale up the care, you can prevent 1.4 million deaths per year. And then this constitutes 14.2% of the total burden of disease in low to medium income country. And the third estimate was done actually by the commission. So the survey was done by the commission. So they did the same thing. They chose 21 disease that is reported in the Hallal metric. and ask 175 surgeons and anesthesiologists and obstetricians what proportion of patients with the following condition would, in an ideal world, require a surgeon for management. And then what they realize is that surgical condition, from this huge data set, comprise 28 to 32% of the overall global burden of the disease. So a significant number of what was reported as disease entity actually will need to have surgery as a treatment. So with these estimates at hand, the Commission asked the important question of how many patients have access to surgery globally. And they define access to surgery by these 4 determinants. Ability to obtain surgical and anesthesia care in a timely way, which means that if a patient fracture their leg, would they be able to get to the hospital within 2 to 3 hours, or it will take them 1 day? The other determinant is existence of a surgical capacity. If they go to the hospital, will they find a surgeon, an anesthetist, or an obstetrician? The third determinant of safe access to surgery is safety, which means, let's suppose there is a surgeon, they were able to get to the hospital. Will there be intraoperative monitoring? Is there a pulse oximeter in the operating room? So this is what they define as safety. And affordability. So basically, if everything, so they pass through the different hoops, and now they're about to go to surgery, can they afford it? Or it will be a catastrophic expenditure. So, and to calculate the estimate of people who cannot access surgery in a timely and safe manner, what they did is that they developed a chance tree to model the probability that an individual has access to surgery and anesthesia in a binary manner, which is 0, 1. So this is what they did. So does the system in this country allow the patient to come to the hospital in a timely manner? Yes or no? And then if it is yes, then is there capacity? Is there a surgeon and anesthetist available? And if it is yes, is it safe? Can the surgeon proceed with the surgery in a safety manner? And then is it affordable, or it will cause major catastrophic expenditure on the patient? So to calculate the probability, it's the probability of T, C, S, and A. And then when they did that, they came up with this staggering number, which is 5 billion. And this is their first message, the first key message. And nobody expected that. But the first key message is that there are 5 billion people who cannot access safe surgery when needed, based on the definition of global surgery and the determinant of the commission. And then this is a heat map that shows where the population, or the 5 billion people who cannot access surgery because they could not hoop into one of the obstacles. And what you see is that 5 billion constitutes 67.3% of the population at that point in time. And what is interesting is that 84 of these 5 billion live in low to medium income country, as opposed to 14% who live in high income country. The second thing that the commission did is that they looked at what constitute a safe workforce. So let's suppose you have a surgeon, anesthetist, you can come in a timely manner, you have everything to control, and then the surgery will not cost a penny. It is covered by the government. How many, they asked the question, how many surgeon, anesthetists, or an obstetrician does a system need per 100 to cover 100,000 population? And then basically they derived from existing data in obstetrics that they need at least 20. They define it as SAO, which is surgeon, anesthetist, and obstetrician provider, 20 in 100,000 to avert mortality. So if the patient lives in a system where there is less than 20 SAO, then most probably the patient will not get a safe access to surgery. And then it is only when the SAO reach 40 where actually the benefit will flatten. So it has to be between 20 and 40. There is no point in making it more than 40, because this is basically will cost a lot, scaling up surgical care. But at least it should not be below 20 per 100,000 population. So briefly, the key message too from their study is that there are 143 million procedures needed annually at minimum globally. And then the poorest 1/3 of the world's population receive only 6.3% of the 331 million procedures worldwide. So there are right now, or at least in 2015, 331 million procedures were done. At that point in time, the global need was an extra 143 million procedure, and 6.3% of the 331 million procedures were done in low to medium income countries. The key message 3 is that there are 88 million individuals that face catastrophic expenditure paying for surgery and anesthesia annually. And they define catastrophic expenditure when the patient needs to pay more than 10% of his income. Key message 4, investing in surgery is affordable, saves life, and promotes economic growth. Without scaling up to 5,000 operations per 100,000 population, low to medium income country will continue to have losses in economic productivity, estimated cumulatively at a staggering number of 12.3 trillion US dollars. This is how much is the effect on the economy if you're unable to scale up to 5,000 operation per 100,000 population. Key message 5 is that surgery is an indivisible, indispensable part of healthcare. So after defining their key messages, the Lancet Commission then defined simple indicator for safe, affordable global access to surgery. And these indicators are that each patient should access safe surgical care within 2 hours. that the facility or the health system should allow for 5,000 procedure per 100,000 population, that the SAO should be 20, above 20 per 100,000 population, that post-operative morbidity and mortality report are essential, and all cause death prior to discharge patient should be reported. The fifth and sixth indicator relate to expenditure, impoverishing expenditure, which is protection against impoverishing expenditure, and indicator for catastrophic expenditure. So these are the indicators that basically the Lancet Commission recommended to measure. And so to give you an example, access to timely essential surgery, proportion of the population that can access within 2 hours a facility that can do cesarean delivery, laparotomy, and treatment of open fracture. And then their target is a minimum of 80% coverage of essential surgical and anesthesia service per country by 2030. So they had all of these targets, they defined them. They had all of these indicators, they defined them, and then they set the target for 2020 and 2030. Important number to remember are workforce 20 per 100,000 population, surgical volume 5,000 per 100,000 population, and then perioperative mortality 80% of the mortality have to be reported by 2020 and 100% by 2030. In terms of expenditure, there should be 100% coverage by 2030. So this is in brief the Lancet Commission on Global Surgery, and I hope by now I was able to clarify a bit what global surgery is and what is its purpose. So in the second part of my presentation, I will discuss the burden of surgical condition in low to medium income countries in the Middle East and the MENA region. In short, I will argue that there are significant gaps in knowledge, in policies, and action regarding surgical conditions, capabilities, accessibilities, and utilization of surgical services across countries in the Middle East. So, an analysis of the burden of disease in the Arab world, Muqdah and his colleague published their study in the Lancet in 2014. And what they did, they compared the disability adjusted life years in 2090 and 2010. So 2090 are the red bar, and then 2010 are the orange bar. And then they categorized burden of disease into communicable, maternal, neonatal, and nutritional disorder, non-communicable disease, and injuries. And then what the result shows is that actually we are better at controlling communicable disease, but actually we are getting worse in controlling non-communicable disease. Now, when you think about it, surgical care is a key element for the treatment of many conditions in bar 3 and 4. And as a result, the increase in this burden should be supplemented by a parallel increase in surgical provision. This is another study that looked at the death rate of non-communicable disease, of communicable and non-communicable disease in the Arab world in 1990 and then 2010. So everything that is in pink is non-communicable disease, and everything that is blue is communicable disease. And you could see that the data still categorized in diseases, not in surgery. So it's stroke, congenital anomalies, cirrhosis, ischemic heart disease. And then what the study that was published by Abdulrahim in Lancet also in 2004 realized is that death, not only DALI, but death is also following the same pattern. So people are more dying from non-communicable disease as opposed to communicable diseases. And then in 2008, 1.2 million people in the Arab world died from non-communicable diseases, accounting for 60% of all deaths in the region. Roughly around 27 in Somalia, 84% in Oman and Lebanon. And 34 of the deaths were in individuals younger than 60%. There is no data on the percentage of patients who died, whether they died because they did not have the surgery or whether they died post-operatively. But we know that they died from non-communicable disease. So while the data about the burden of disease in the Middle East is limited, the information related to the human and the economic effect of surgical condition, the state of the surgical care, and the potential for scaling up surgical service is totally insufficient. And this has been reported by Kafarani and his colleague in the Handbook of Healthcare in the Arab World and published in 2021. So the Lancet Commission in 2015 reported that the estimated needs in the MENA region, not in the Middle East, in the MENA region, is 19.9 million surgical cases. Okay. So basically, the MENA region was doing 4,456 cases per 100,000 population. And then so the estimated unmet need in the region, just in the MENA region, is 2,100,000 surgical cases. And then we're still missing around 500 cases per 100,000 population to reach the minimum target of 5,000 cases per 100,000 population. How about the surgically avertible burden in the MENA region? And then so specifically related to surgery, Professor Higashi published his result in surgery in 2015, and he calculated the potential decrease in burden of digestive diseases if a quality surgical service were available. And then so basically his study was a global study, and then all I did is I extracted the data that is pertinent to the MENA region. Okay. So what the graph is showing you is that in the MENA region, if you scale up surgical care to the level that meets the target of the Lancet Commission, you'll be able to prevent 1,000 deaths from simple appendicitis a year, which is basically represent a 76% reduction in mortality. When you look at intestinal obstruction, you'll be able to save the life of 4,000 something, a reduction in 52%. Gallbladder disease, same thing, 2,000. And then so basically for the total of the 4 digestive disease, if you scale up care, we'll be able to save the life of more than 7,000 people per year. And then it is the same thing when you look at, it is the same thing when you look at it from an economical point of view. And then YLL is that year of life lost. And the DALI is the adjusted life lost. So basically, you could see that basically, if you scale up, you will not affect YLL and DALI as compared to mortality. No. While the previous paper reported the avertible burden of certain surgical condition, the following paper, the one I'm going to show you right now, analyzed the global economical burden if unmet surgical need for appendicitis. Okay. So this is a collaborative research led by the National Institute of Health Research on global surgery, and it was published in British Journals of Surgery in 2020. And then, so the paper report information related to different regions in the world, and I will present to you only the data related to the Eastern Mediterranean, Europe, and the world. Their definition of Eastern Mediterranean is a bit non-conventional. So Afghanistan and Pakistan was part of Eastern Mediterranean. There was no data from Syria in that report. So basically, when you look at this table, you realize that in the Eastern Mediterranean, the incidence of appendicitis per 100,000 population is 264, in Europe is 232, and then in world is 262, which is basically the same. And the Eastern Mediterranean area, 3,305, around 3,300 cases are done per 100,000, which is way less than the 5,000 per 100,000, as opposed to 8,000 per 100,000 in Europe, which is expected. The Eastern Mediterranean performed 112 appendectomy per 100,000, in Europe 181, and in the world 142. So, because of the fact that the target was not reached, that 3,300 surgery are done only per 100,000 population are done only in the Eastern Mediterranean region, as opposed to 5,000 per 100,000 population. There is an unmet need of appendectomy in 35% of the population. And then when you look at the total economic burden of not doing this appendectomy, there is a 7,921 million US dollar loss. And that constitutes around 12.5% of the GDP of the region. So the challenges. The first challenge is the financial coverage. So this is the WHA 58.33, a document of the WHO resolution and decision. And this document stipulates that prepayment and pooling of resources are basic principles in financial risk protection, and urges members to ensure that health financing include a method for prepayment of final contribution of healthcare. And then so this is a heat map that shows the percentage of domestic general government health expenditure. So this is the percentage. And you could see in the MENA region, the percentage of the budget that is spent on health is practically dismal. At best is 2.66%. This is data from the World Bank. So the path in the Arab world seems to be heading in the other direction than WHA 58.33, with an emphasis on the privatization policy and on diminishing the allocation of government resources to healthcare. And this has been published by Shadi Saleh et al., and then also published in the Lancet in 2014. How about the workforce? We are barely there. I'm not sure if you could see it, but we are, I mean, the workforce in the MENA region is around 22 SAO per 100,000 population. I just want to remind you that at 20, below 20, you start seeing an increase in the mortality. How about the risk of catastrophic expenditure for surgical care? And you could see that within the MENA region, there is a significant proportion of the population that is at a risk of catastrophic expenditure. It is estimated around 10%, so 10 to 15%. This is 2018 data. How about data? And then so if you cannot measure it, you cannot improve it. If you can't measure it, you can't manage it. It is unclear who first came up with this quote. It has been attributed to Lord Kelvin and then to Peter Drucker. So the WHO health system framework has 6 building blocks for health, which are service delivery, health workforce, health information system, access to essential medicine or surgery, financing, and governance. And then these blocks are essential. You need to have them if the aim, goals, is improvement in health, right? However, the only way you can do that is by, 1, making sure that the coverage is affordable. 2, by improving quality. So monitoring and evaluation is an essential tool for strengthening health system. And to do this, it is of paramount importance to have a proper data system that can gather accurate data to analyze in a scientific manner, to drive health policy, and to assess the progress and the performance. However, when you read all the publication, the message seems to be uniform. The low to medium income country in the Arab world lag behind on information technology and data collection, and there is lack of access to the national data set. And if there is an access, then transparency is questioned. How about surgical capacity and provision of essential care? The data is scarce, and it is complicated by an important factor that I will discuss shortly, which is continuous conflict in the refugee crisis. So in 2019, Professor Kafarani from MGH analyzed the surgical capacity in all the private hospital and public hospital in Lebanon. There are 103 private hospital and 26 public hospital in Lebanon. He defined the surgical capacity based on pipes, which is here, capital P, capital I, capital P, capital E, capital S. And what pipes measure is, the first P is personnel. Is there personnel? 2, infrastructure. It's defined how you can score. Procedure. How many procedure does the hospital do? Equipment is the equipment within the hospital accurate, good, and then supplies. Okay, and then you come up with a score. So The private hospital had a mean hospital bed of 90, while the public hospital had 57. And then what he realized is that there is a significant discrepancy between the PIPE score or the individual PIPE score when it comes to personnel and infrastructure, and the overall PIPE score between public health and private health, between public hospital and private hospitals. So what he looked at after that is basically at the geographical location of the hospital. And then he mapped where the Syrian refugee are. And what I realized is that the PIPE score is also significantly lower whenever you have a hospital that is within an area where the percentage of refugee is high, above 25 to 30% of the population. So he concluded that surgical capacity in Lebanon reveals significant gaps and deficiencies, most pronounced in public hospital in which refugee care is provided and in area with the highest refugee concentration. So, conflict medicine. The MENA and mainly the Middle East has been plagued with conflict for the last 70 years. There is an estimate of 37% of 70.8 million displaced worldwide are only from the MENA region. The conflict will lead to complex related injuries, war-related illnesses, chronic condition from complex wound necessitating long-term care, surge in the resistance of communicable diseases, and major psychological trauma. But also an observable drop in research and data collection and analysis. I will only emphasize this point because I think it is important. So this paper, a comparison between health research output and burden of disease in Arab countries, evidence from Palestine, which was published in 2018. This paper discussed the comparison between health research output and burden of disease in the Arab country, and taking as an example Palestine. And so basically, the author reported that the research output, which is on the y-axis, correlates poorly with the burden of the disease, with a Spearman row of 0.11 and then 0.22. So whether you're reporting deaths or you're reporting DALI. We have too many deaths and very few research output to explain that, and then too many DALI and then very few research output. And then so to further assess the association and proportionality between research output and disease burden, the author examined the actual, observed, and expected number of study as a function of the disease burden. And then what they realize is that we report way lower than expected. And so basically, in their discussion, they attributed that to the researcher interest and expertise in the conflict zone, that there is a limited research infrastructure and funding resources, and there is a lack of communication between policymakers and researchers to agree on a national research priorities. But there might be another reason, which is the ecology of war. And then I'm including maybe a new term, but it is important to define it because it is important in the understanding of conflict medicine and global surgery. So ecology is the result of protracted conflicts which maintain themselves well beyond the end of shooting and alter the living environment of people who struggle with physical, psychological, and social wounds. With the deliberate destruction of health provision and the repeating cycle of infection, injury, poverty, and human misery, all of which become a permanent reality. So what this creates is a subjugated knowledge. And then the argument for this subjugated knowledge is that, one, the knowledge is deprioritized. Research and development, because the priority is the conflict. It is important to note that research and development expenditure average around 0.93% of GDP in the MENA region, and that the MENA contribute to 1.5% of the research production. The other reason, the other argument for the subjugation is shortage of available, reliable, and transparent data. And the third one is securitization theory. And then, so basically, securitization theory is that political and armed group within a conflict looked at data regarding population figures, mortality, and spread of disease, a highly politicized issue and threatening to security. So this is the World Bank data, which basically looked at the statistical capacity of the MENA region. Statistical capacity is a term that includes aspects of data quality as well as accessibility. And these are two important ingredients of transparency. And what they realized is that the MENA was the only region in the world to experience a decline in statistical capacity, which means transparency, between 2005 and 2018. So actually, we're regressing. And then I'm gonna read to you this statement. In early 2001, we experienced an instance of what could be fallout of the ethical issues of research in conflict-affected countries. In an interview with the director of welfare organization in South Lebanon, the first question asked was, "Have you come to write lies about us?" We had to assure him that we were there to explore health and welfare provision in a country affected by prolonged conflict. So, recommendation. I think we should not reinvent the wheel, and I think we should advocate for the measurement of the Lancet indicator metric to drive policy through a national surgical plan to optimize infrastructure, workforce, service delivery, financing, and information management. My other recommendation is related to medical education. This is Professor James Steiner. And James Steiner actually was flying with his kids in Nebraska, and then he was flying his own airplane. And then the airplane went down. And so basically, he could not get any help. And then he came up with that statement: when I can provide better care in the field with limited resources than what my children and I receive at the primary care facility, there is something wrong with the system, and the system has to be changed. He realized that there is a need to improve the trauma system. And then that was in 1977. And then in the United States now, it's like one of the best trauma care in the whole world. And then basically, they had exported their knowledge to the rest of the globe. And I think we are at the same stage when discussing conflict. I think the breadth of knowledge and skills needed in conflict is not taught, but learned from experience. So basically, from experience, I know how to deal with a war injured, but I was never taught how to do that. Never. I think it's time, like Professor Skinner, it's time to think about it from a different perspective. And I think it's time to integrate conflict medicine in medical education, because it goes beyond treating war injury. It basically involves social skills and ethical consideration, education on health system and health policy, treatment of injured patient, surgical procedure, and epidemiology. Education system will be able to produce a new generation of healthcare professionals who are better equipped to deal with the specificities of the region's health system by learning different ways in which health in conflict is conceptualized and operationalized. In conclusion, at the present, there is a gross global inequity in the burden of surgical condition in the low to medium income countries, specifically in the Middle East. A national surgical plan to scale up care is essential. Research, monitoring, and assessment play a crucial part in the future of global surgery. And then introduction of conflict medicine in the medical curriculum might be a consideration. This is the WHO Director General, Mr. Mahler speech. So he had a speech in 1980 where he says that social injustice is socially unjust in any field of endeavor, and the world will not tolerate it for much longer. So the distribution of surgical resources in countries and throughout the world must come under scrutiny in the same way as any other intellectual, scientific, technical, social, or economic commodity. The era of only the best for the few and nothing for the many is drawing to a close. I think it was true in 1980, and then it is still true in some part of the world. And with that, I conclude my presentation, and I thank you, and I'm looking forward to answer your questions. Thank you.
Thank you very much, Dr. Hallal, for that very enlightening presentation.